bilirubin metabolism. So in this topic we'll be discussing about all these mechanisms right here, right? We'll be talking about bilirubin metabolism, we'll be talking about different type of hyperbilirubinemia, and we'll be talking about all these things. So let us begin our discussion. Now initially the thing that we need to understand is bilirubin. Okay, how is bilirubin formed? Okay, initially what we have RBC, right? We have RBC. Now this RBC, the lifespan of RBC is 120 days, right? 120 days. Now after 121 days, what will happen is our spleen, right? Spleen and our reticuloendothelial system, right? What will happen is these RBC will be destroyed by our these things, right? So the spleen is also called what? The graveyard of RBC. So the RBC destruction will occur at 120 days, right, in spleen or reticuloendothelial system. Okay, now what will happen on the being destruction on RBC being destroyed? There are two things, right? One is heme and another is globulin. Now this globulin will be taken up by macrophages, right? Splenic macrophages, and the remaining portion is our heme. Now what will happen to this heme? This heme will be, what it will happen is this heme will be converted into what? Our biliverdin. Now it will be converted to biliverdin with the help of our heme oxygenase. Now this biliverdin, what will happen is this biliverdin will be reduced, right? And this will be reduced to our unconjugated bilirubin. So this is how unconjugated bilirubin is formed, and this unconjugated bilirubin is also called what? Indirect bilirubin. Now what will happen is this unconjugated bilirubin, the one of the important fact about this unconjugated bilirubin is this unconjugated bilirubin is lipid soluble, right? Lipid soluble. Okay, since it is lipid soluble, right, it cannot since it is lipid soluble, it cannot be excreted out in what? Our urine, right? Urine or stool. So what will happen is this unconjugated bilirubin will combine with albumin, right? Albumin, and then it will remain in blood circulation. Now as it will remain in blood circulation, now it will go into liver, right? It will go into liver. You can see UCB, unconjugated bilirubin, right? Now unconjugated bilirubin on going to liver, it will combine with UDP, right? Now with the help of enzyme UGT. Now what is this UGT? This UGT is UDP glucuronide transferase, right? What is this? UDP glucuronide transferase. Now this UDP, what it will do is it will convert this unconjugated bilirubin into conjugated bilirubin. Okay, now this conjugated bilirubin, what will happen is this conjugated bilirubin will move through what? Biliary duct, right? Move through biliary duct, and it will go into intestine. Now since we know intestine consists of what? Intestine consists of gut bacteria as what? Normal flora, right? Normal flora. Okay, before getting into that, okay, the important thing that I missed here is this conjugated bilirubin. Since we are telling this unconjugated bilirubin as lipid soluble, right? Lipid soluble, but this conjugated bilirubin, it is our what? Water soluble, right? Water soluble. And the important enzyme that is taking place here is our UDP glucuronide transferase, right? Okay, now since I said that these are going to pass through biliary duct, right? Biliary duct, and they will reach into intestine. In intestine we have normal flora, bacteria, right? Now these bacteria have what? They have glucuronidase enzyme. What they have is glucuronidase enzyme. Now what this glucuronidase enzyme will do is they will convert this conjugated bilirubin into what? Into our stercobilinogen, and we have urobilinogen. Now what is this stercobilinogen? It is a factor that will cause what? That will cause our color of skin, right? That will cause the distinctive color of skin. And what about our urobilinogen? This urobilinogen, it will cause the color of our urine, right? Urine. Okay, here the thing mentioned are UGT, the most important one, UDP glucuronide transferase, right? Similarly what we have is we have UCB. What is this UCB? Unconjugated bilirubin. This is lipid soluble, right? And we have CB. What is this CB? This is conjugated bilirubin. What is this? This is water soluble. Okay, now now here we can just Okay, let us suppose there is one condition. The condition is that we have defect here, right here, okay, in this area. If we have defect right here in this area, then our unconjugated bilirubin will not be able to convert into our conjugated bilirubin, because of which the unconjugated bilirubin level will go up, right? It will go up. Okay, now what happen if there will be defect right here in biliary duct area, right? Biliary duct area. If there will be defect in this area, what will happen is the conjugated bilirubin level will go high. Okay, there are two conditions we spoke right now. One is the level of conjugated bilirubin going up, and another is the level of unconjugated bilirubin going up. So these two condition is what we call jaundice, right? Jaundice. What is jaundice? It is the increase in level of unconjugated bilirubin or the increase in level of conjugated bilirubin. Now, okay, that means we are talking about increase in amount of bilirubin. Okay, let us talk what is the normal amount of bilirubin. I mean, in normal individual, what is its amount? Its amount is 0.1 milligram per deciliter to 1 milligram per deciliter. Now, okay, now above, if there will be rise in bilirubin level above 2.5 milligram per deciliter, then we call this condition as jaundice, right? We call this condition as jaundice. Now, we said in jaundice there are two types. We have increase in what unconjugated bilirubin level or the increase in conjugated bilirubin level. So talking about the specific condition, right? At what time we will say that it is jaundice in which there is unconjugated bilirubin level, right, higher. So if the total bilirubin content is greater than 80%, right? Total bilirubin means what? In bilirubin we have conjugated and unconjugated both, right? So if in this condition we have what? 80% unconjugated bilirubin, right, and 20% bilirubin conjugated bilirubin, then this condition is what? And here we are talking about what? Greater than 2.5 milligram per deciliter, right? It should be higher than this. So this is how, what is this? This is the condition of unconjugated hyperbilirubinemia. Okay, now talking about what? Conjugated, it should be greater than 50, right? Greater than 50. Okay, now, okay, we talked about the levels, right? The levels in which we will be calling it jaundice. So now, just by appearance, how we will find out that the person is suffering from jaundice? So one important thing here is there will be allo discoloration of skin and sclera. It's important, skin and sclera. And if we correlate it with anatomy, then what we'll find here is the affinity of bilirubin is maximum in elastin fibers. That means the places where there will be the maximum concentration of elastin fibers, there will find a maximum amount of bilirubin, and the maximum amount of elastin fibers they will be found in our skin and scleras. So we'll find alloys discoloration in these areas, right? Okay, we'll find bilirubin going there and being depositing there. Okay, now moving further, what we need to understand here is there is on following the fact, we have what? We have linkage of pharmacology, right? We have linkage of pharmacology, and we're talking about the linkage of pharmacology, that there are other conditions in which there is alloys discoloration, right? Okay, there is a condition in which in ingesting quinones, right, earlierly used as anti-malarial drug, right, on ingesting them we also have what? Alloys discoloration. And another important thing that we need to mention right here is on ingesting a large amount of carrot, which consists of carotenes, also causes alloys discoloration. But here on ingesting carrot, right, we will have alloys discoloration only on skin but not on sclera. So that is most important thing, right? Diagnostic feature, right? Will coming to distinguish between what? The alloys discoloration because of what? Because of our carrot intake, and another what? Another we have because of what? Because of jaundice. So that is the thing. So we talked about pharmacological link, in which we said that quinolones, which were earlier used as anti-malarial drug, and another thing is we talked about what? Carrot, right? On ingesting carrot we also have what? Alloys discoloration, but only in what? Skin, not on sclera. Okay, now moving further, yes, we have mentioned already these things. Unconjugated hyperbilirubinemia, it is the condition in which there will be more than 80% of unconjugated bilirubin out of total bilirubin. And conjugated hyperbilirubinemia, right, conjugated bilirubin is more than 50% of total bilirubin. That's all. Now moving further, right, we'll be talking in detail about unconjugated hyperbilirubinemia, right, unconjugated hyper. Okay, that means here the level of this is going higher. Okay, the first cause of unconjugated hyperbilirubinemia is our RBC destruction, right. As there will be the higher number of RBC destruction, there will be a release of higher number of heme, right, and we know heme is eventually going to convert into unconjugated bilirubin. Okay, now here the first thing that will cause increase in RBC destruction is hemolytic anemia, right. In the case of hemolytic anemia, there are other cases also, right, such as what we have hemorrhage, we have what premature erythropoiesis, right, ineffective erythropoiesis at the time also. Similarly, in the case of what, in the case of liver immaturity. Now talking about liver immaturity, this condition, what will happen in the case of liver immaturity is there will be reduction in what, reduction in function of, we have what, UDP glucuronide transferase, right. If there will be ineffective glucuronide transferase, here you can see right here, there will be what, less conversion of unconjugated bilirubin into conjugated bilirubin, and that will lead to what, unconjugated hyperbilirubinemia. Okay, right here, liver immaturity, this is seen in newborn, right. In newborn, the liver, hepatocyte of liver is not fully functioned, or in liver what we have seen is there will be what, there will be no functional liver. And talking about fact, in newborn baby, the liver is not completely developed till second week. What, till second week. Okay, after second week the liver is completely developed. Okay, now this condition, right, in which the newborn will be suffered from unconjugated hyperbilirubinemia, it is called physiological jaundice. Okay, it is exactly seen on second day onwards, If there will be any case in which there will be hyperbilirubinemia in child within 24 hours, then that will be not considered as physiological jaundice, that will be pathological condition. We are saying specifically that on the second day, right. Okay, now since we are talking about newborn jaundice, physiological jaundice, right, there is breast milk jaundice also. And what is this breast milk jaundice, right? Breast milk consists of what? It consists of glucuronidase. It consists of glucuronidase, which is pregnenolone in breast milk. It is pregnenolone in breastfeeds, and it is glucuronidase, right. It will also help in enhancing what? Enhancing the level of unconjugated hyperbilirubinemia. Okay, now this was about what? This was about unconjugated bilirubinemia, right. Now there are genetic factors that will also cause increase in what? Unconjugated hyperbilirubinemia. Now what are the genetic defect? Okay, the first thing is we need to understand that hyperbilirubinemia will be result because of what? UGT defect, right, UDP glucuronide transferase defect, right. And these defects occur in our these two condition. What is this two condition? Our Gilbert syndrome and Crigler-Najjar syndrome. We don't need to get panic right here, the name are only difficult, but we'll get into it so easily. Okay, the first condition is Gilbert syndrome. Now what is this Gilbert syndrome? Okay, there is one case, right, there is one patient that is coming to you. That patient is coming to you and he is young, and he is coming to you, right, he is coming to you and he is coming to you after getting stress, right. A young guy after getting stress will come to you with a condition of jaundice, right. At that time what we need to know is that he is suffering from Gilbert syndrome, right. He is suffering from Gilbert syndrome. Okay, now what is this condition? Simply this condition, in this both condition there is reduction in UGT activity. Now in Gilbert syndrome what is going on is there is, right, UGT, right, there is UGT, but it is functioning only in 30%, right. It is functioning of its total capacity about 30%. It is functioning about 30% of its total capacity, right. So what is going on here is we say that adult with common stress. Why we are not talking about children? We are not talking about children because in Gilbert syndrome the amount of UGT, right, which is working is 30%, and this 30% is enough for children, right, it is enough for children to perform its function, right. So the children in children there is a symptomatic condition. So as children will grow up and turn into adult, right, now at this time at adult stage he or she will require what, he or she will require full functioning UGT, right, and we have already mentioned that here the person is having only 30% of what, UGT working. So he will come with what, the feature of jaundice, right, feature of jaundice. So how we will just memorize this thing, we will memorize this thing as from Gilbert we have G, right. So now adult guy, right, adult guy, okay, adult guy, and we mentioned about syndrome when we have S and stress, adult guy with stress, right, adult guy with young guy after stress. So and another thing is this Gilbert syndrome, right, this Gilbert syndrome is resulting because of two things. What are the two things? The first thing is it is resulting because of promoter right mutation. One is promoter mutation and another is we have what, nonsense mutation, right, okay, that's not nonsense, that's missense mutation, missense mutation. Okay, this promoter mutation it is autosomal recessive type, and this missense mutation it is autosomal dominant type. As you can see R here, right, and just highlight the end of this R. Okay, so promoter mutation, and what is another, we have missense mutation. So we talked about Gilbert syndrome. Okay, whatever we said about Gilbert syndrome is there will be a young adult, there is young adult guy, right, who will come with jaundice symptoms after getting stress, right, and we said that it is because of two things. One is because of what, promoter region mutation, and another is we have missense mutation. Now promoter region mutation, right, in promoter we have indeed we have R at the last, and we will say that it is what, autosomal recessive, and in missense mutation it is what, it is our autosomal dominant. Okay, now talking about Crigler-Najjar syndrome. What is this Crigler-Najjar syndrome? It's so easy, right. Here this Crigler-Najjar syndrome will have its relation with pediatrics, right, it will correlate with pediatrics, it has pediatrics link. Now here as you can see you will pick the word C, right, and you will pick the word N. Now from C we have children, right, children, from N we have newborn, okay, newborn. So what is going on here is we are talking about what, as we have already mentioned, it has what, pediatric link. So here what we have is it has got two type, the type 1 and type 2. Talking about type 1, right, in type 1 it is so severe type that there is no activity of enzyme, that means glucuronide transferase, UDP glucuronide transferase will not what, it is not acting at all, right, and this will result in death of child, right, this will result in death of child. How it will result in death of child is that since there is no what, there is no functioning of UGT, so the unconjugated bilirubin, right, unconjugated bilirubin will not be converted into conjugated bilirubin, right, and there will be the high amount of unconjugated bilirubin. As the amount of unconjugated bilirubin will be so high, right, what it will do, it was what, it was combining with albumin, right. Now what it will do is it will saturate albumin, right, and as it will saturate albumin, right, what will happen that it will what, cross blood brain barrier, and as it will cross blood brain barrier, what will happen, it will reach basal ganglia, right, where it will reach basal ganglia. Okay, on reaching basal ganglia it will go and it will be deposited right there, right, and it will cause what, permanent brain damage. Now what is this permanent brain damage called? It is called cornectus. What it is called? It is called cornectus. Okay, this condition is called cornectus. Okay, so this CNS type 1 is so dangerous, there is no activity of enzyme and increase in mortality is so high. Now talking about type 2, right, talking about type 2 condition, what is going on here is there is less activity of enzyme. What is there? There is less activity of enzyme, right. Okay, okay, there is less activity of enzyme, right. Okay, there can be what, neurological symptom also because of what, unconjugated bilirubin deposition into basal ganglia, but it is not fatal as what our CNS type 1, which was causing what cornectus, right, cornectus. Okay, now here what is going on is, since it is here there is inhibition of activity of enzyme UGT, right. So in order to enhance its activity, we are trying to provide inducers, and we know the inducers are what, the inducers are our phenobarbital, right, phenobarbital. Okay, if you remember the acronym GPRS cell phone, we have what, phenobarbital, right, phenobarbital will enhance the activity of UGT, right, and there will be what, there will be less reduction in its less reduction in symptom of jaundice. So another therapy is also there, that is phototherapy. Now what is this phototherapy? Phototherapy is a mechanism in which we are passing blue light, right, by covering eye region and genital region, so that they will be not affected. So what will happen in this phototherapy is that the unconjugated bilirubin, right, will be converted into something that is water soluble, right, that is water soluble, that is bilirubin, right, bilirubin is water soluble, right. Since it is water soluble, it will be excreted out of our body, So as I have seen, it is seen in children and newborn. Yes, CN, yes, CN, right, CN we have already discussed, and it is autosomal recessive syndrome. Yes, it is autosomal recessive syndrome. The both of these things are autosomal recessive syndrome. Okay, now what we till now what we have discussed, till now we have discussed about unconjugated hyperbilirubinemia, right. We talked about unconjugated hyperbilirubinemia, right. We talked about genetic defect, Gilbert syndrome, and Crigler-Najjar syndrome. Okay, now moving further, we have conjugated hyperbilirubinemia. Now what is this conjugated hyperbilirubinemia? Okay, it is because of what, because of defect in what, because of defect in passage of conjugated bilirubin, right. Okay, now now here talking about here, right, what is the result of conjugated hyperbilirubinemia? Obviously jaundice, we have pruritus. Now what is pruritus? Skin itching, right. Since bilirubin has high volume of distribution, it will reach into what, our different part, our skin, our root of our hair. Another, it results in clay coloration, right. It will cause what, clay colored stool. Okay, steatorrhea, right, steatorrhea, dark colored urine will be there. Okay, now what is the cause of our conjugated hyperbilirubinemia? Since okay, conjugated hyperbilirubinemia is because of defect in this region, right. Okay, now let us move toward right here. Okay, one is the major cause is because of bile duct obstruction, right, bile duct obstruction. Since there will be no bile duct, the thing that will help in passage of conjugated bilirubin, right, into intestine, since our duct will be what, obstructed because of what, stones, cancer, right, cancer in elderly people, infection because of what, liver flukes. Okay, there will be what, there will be conjugated hyperbilirubinemia. Now another is biliary tract disease. Okay, the biliary tract disease, okay, these are primary biliary cirrhosis and primary sclerosing cholangitis. Now this primary biliary cirrhosis and primary sclerosis cholangitis, these are detailedly studied in what, our biliary tract disease topic itself. So we will not go this thing in detail right here. Now we will be talking about genetic disease, right, genetic disease because of what, decrease in excretion of our conjugated bilirubin, right. Okay, the one is Dubin-Johnson syndrome and another is Rotor syndrome. Now what is this Dubin-Johnson syndrome? Now this Dubin-Johnson syndrome, what is this? This Dubin-Johnson syndrome is, right, it is characterized by presence of dark, you can see dark pigmented liver, right. Okay, Dubin-Johnson, it is presented by what, dark pigmented liver. Now this dark pigmented liver, it is not because of deposition of conjugated bilirubin in liver, it is because of what, epinephrine metabolized, deposition of epinephrine metabolized. Right here you will see what, you will see increase in size of liver, right. Right here what you will see is there will be MRP2 defect. Now what is this MRP2 defect? It is multi drug resistant protein 2, right. What is this? Multi, right, drug resistant, right, multi drug resistance protein 2. Now what is significance of this multi drug resistance protein 2 is that it help in what, it help in excretion of conjugated bilirubin, right. It is canalicular protein, canalicular protein. Now its function is that it will help in excretion of conjugated bilirubin. So since there will be defect in this protein, what will happen? Our conjugated bilirubin will not be excreted out, and what will happen? That it will remain right there, and it is of autosomal recessive type. Right, now talking about Rotor syndrome. Now what is this Rotor syndrome? Right, Rotor syndrome, the distinguishing feature of Rotor syndrome is that here the liver is normal, whereas in above Dubin-Johnson syndrome we had pigmented liver, right, dark pigmented liver. Okay, here what will happen is, here it is because of what? Because of our what? Defect in OAT proteins. Right, now what are these OAT proteins? These are organic anionic transporter, right? These Rotor syndrome is because of defect in organic anionic transporter, right? Organic anionic transporter, because of which there will be not passage of our what? Conjugated bilirubin, and it will result in these things. So this was about what? This was about our bilirubin metabolism and jaundice. So this much for this lecture.